Bismillah ar-Rahman ar-Rahim. Welcome to VIVA, Easy Radiology Approach. I'm Dr. Muhammad Talat, Assistant Professor of Radiology at University. Today, inshallah, we have VIVA session, second VIVA session GIT cases. The common complaint for our cases is abdominal pain.
Yes, sir.
Okay. You are free to scroll.
Okay, sir. So do we have any history or should I start?
Abdominal pain, yeah.
Okay, sir.
Young adult.
I'm provided with non-contrast CT scan of a young patient who presented with abdominal pain. First, I'll scroll the entire stack before giving any opinion. The obvious abnormality that catches my eye was this diffusely thickened sigmoid colon with significant stranding and inflammation noted. I also appreciate that the sigmoid colon is, it's slightly, I think it's the large bowel. I'm trying to follow the large bowel. I could appreciate that sigmoid is continuing in the.
Yes.
Yeah, it's on the right side.
Yeah, you are
And
right.
then, it's redundant, I think, because I could also appreciate the ascending colon. That is in normal position.
Mm-hmm.
And there is a large redundant sigmoid colon with significant stranding and inflammation. I could also appreciate few additional diverticuli in the sigmoid colon and stranding as well. So I'm thinking of sigmoid diverticulitis as my first differential. And I would like a post-contrast scan to see any associated complication like the IMV thrombus or any fistula formation. Although on the given sequences, I could not appreciate any clear fistulous tract, but I would like to evaluate it with a post-contrast scan.
Okay, can we check the coronal plane?
Yes, sir, sure.
Okay.
Yeah, so I could, the coronal plane reconfirms my finding of inflammation around the sigmoid colon with few tiny nodules noted within it. So I'm thinking of, again, complicated diverticulitis in a redundant sigmoid colon. And yes, and no other abnormality on the non-contrast coronal section I could appreciate.
Okay. Thank you, Kent Namron. You did very well because I think the first that you could identify the anatomy very well. If we want to review the axial plane again, I think as you said, this is the rectum and this is the sigmoid colon and sigmoid colon directed to the right side. And I'm happy that you didn't call it ascending colon because the ascending colon is, as you see here, it's posteriorly, and this is the appendix. Appendix is free. And the sigmoid colon is going to the right side and curving to the midline and returning back to the left side here to make the descending colon. So we have some sort of dolicho colon, and this dolicho colon, as you said, we have focal smudging of the pericolic fat planes, and we have small diverticular outpouch here. And I think the first possibility is acute diverticulitis. Here, this is the diverticular outpouch. But I would like to ask you, is it perforated or not perforated?
Sir, I could appreciate a tiny ear locule outside the lumen. So I
this
think
one.
Yeah.
This one. Yeah, you are right. Okay. So we have diverticular outpouches, but one of these diverticular outpouches is thickened, surrounded by smudged fat planes, and we have a very tiny extraluminal gas pocket. So please take care of this point, because when I started to report this case, I thought at the first that it may not be perforated, but when I focused again at this abnormality, I found this gas pocket, extraluminal gas pocket. So we have acute diverticulitis complicated by micro perforation or sealed perforation. At least you can say this one. Okay, for close follow-up. Really, in the second day, we did CT scan for the patient, with oral and IV contrast. Did you find anything extra?
I'm looking
You
at
are
it.
free to scroll. You are free to
Okay,
scroll
sir.
if you
Okay, sir. So just give me a second. So I'm now looking at the post-contrast sequences of the
want.
patient.
Mm-hmm.
I could appreciate the appendix that appears
Mm-hmm.
normal. I am now moving to my region of interest.
Mm-hmm. Mm-hmm.
There, I could appreciate that significant stranding,
Yes.
and I think it's no, it's in close contact with the bowel loop, but there is no obvious communication with it. I want to
Okay.
see. I am in inferior mesenteric vein
Mm-hmm.
to see any possible thrombus.
Yeah.
Uh,
Did you find
but
any thrombus or mesenteric
sir,
vein
I think
thrombus?
sir, I would like to see it on the axial as the anatomy is
Okay.
already shifted, so I cannot comment on the coronals
Just a
about
minute.
the. Yes, sir.
Just a minute. I'm sorry.
Yes, sir.
Okay. This is the axial plane.
Yeah, yeah. Sir, I could. I'm now. I'm looking at the vessel.
I
Sir,
think we
I
don't
would like
have
to.
any thrombosis of the mesenteric
Yeah.
veins. Mesenteric veins are
Yes, sir.
patent. Okay,
Yeah. So
so we
just
don't
there is
have any
prominent.
thrombophlebotitis. Yeah,
Sir, just they are dilated vessels, but they appear patent. The vessels
yeah,
supplying air are inflamed, and there is significant pericolic stranding and
yeah.
thickening. But yeah, the vessel appear patent.
There was
Contrast
a
is seen
progression.
behind.
There was a
Yes,
progression
sir.
of the inflammatory changes, and also the gas pocket. I think now is larger in size, as you see
Yes, sir.
here. It's more obvious that we have a perforated acute diverticulitis, and as you said, we have to exclude any face-to-face communication between this bowel loop and the nearby small bowel or the urinary bladder or something like this. I think, yeah, this case was managed conservatively, alhamdulillah, successfully, and in the follow-up, it was totally resolved. Thank you so much, candidate number one. The most common complications in this case, pneumoperitoneum, thrombophlebitis of the mesenteric veins, mesenteric vein thrombosis, also face-to-face communications. All of these are very important. Also, the next step, also after the resolution of this acute attack endoscopy, is very important to exclude underlying malignancy. Okay, thank you so much. Can we move to candidate number two,
Thank you,
please?
sir.
Welcome.
Assalamu alaikum, sir.
Walaikum salam wa barakatuh. How are you?
I am good, sir. Alhamdulillah. How are you?
Alhamdulillah, fine. You are lucky, candidate number two. Are you lucky? What do you think?
Yes, sir.
In your life? Okay. Uh, really, I have a problem, technical problem in my session today that my pen is not working. So I will try to localize the abnormality by the mouse. Okay. Okay. Candidate number two.
Yes, sir.
Candidate number two. We have acute abdominal pain. If you want to scroll.
Okay, sir. I'm asking for the control.
Okay.
Sir, I have requested the remote control.
Okay. Yeah. Go ahead. Abdominal
Okay, sir.
pain.
Okay, sir. I'm presented with a CT scan,
Mm-hmm.
axial slices of a patient who presented with abdominal pain.
Mm-hmm.
And first of all, am going to the top and then scroll throughout the entire stack. This is
Mm-hmm.
non-contrast CT chest abdomen, and
Yeah.
I will quickly go scroll through the chest as the patient has presented with abdominal pain. And then in the abdomen I can appreciate that uh, in the confinement of the non-contrast study, liver, spleen, kidney, pancreas and
Mm-hmm.
liver are unremarkable. I can appreciate that uh, the transverse and ascending colon are dilated.
Yeah.
And then as I scroll down, I'll scroll down till the last cut, and then I'll come back and trace the colon once again. So the rectum is collapsed, and now I will from down. I will trace the rectum.
Mm-hmm.
Okay, sir, I am
Very good.
scrolling upward. Sir, the rectum is collapsed, and then
Yes.
as I go into the sigmoid colon,
Yeah.
uh, Okay, I have a suspicion of some. Okay, okay, sir. I'm scrolling it, and sir, now in the portion of the sigmoid colon, there is dilatation seen, and then as I scroll it further, okay, sir. Now I'm in the transverse colon, and
Yeah, you are right. We have
yes, sir.
a significant dilatation of the large bowel,
Yes, sir.
more severe at the ascending colon and cecum.
At the ascending colon, yes,
Yeah,
sir, and the
you are
cecum.
right.
And
Okay,
then sir, the ileocecal junction, I'll comment on the ileocecal junction,
okay.
which the appendix is normal, and so as the
Yeah, you
ileocecal
are right.
junction. Yes, sir.
Very good.
Sir, so the only transition point I could see is was that in this region, where there
Yeah.
is significant caliber change, and then I have a suspicion of circumferential mural thickening. No
Mm-hmm.
pericolic standing is noted, and I cannot appreciate any lymph nodes. So,
Mm-hmm.
sir, I would in my routine practice, I'll measure the diameter of transverse colon and cecum, and sir, I'll refer the patient to surgical onco. First of all, I will advise post-contrast scan for the
Okay.
evaluation and delineation of this area.
Yeah.
And I'll
Unfortunately,
also,
the patient was not prepared to give IV contrast at that time. This is
okay,
uh,
sir.
this is what happened with me in my practice.
Okay, sir. Okay, sir. Sir, then, sir, I'll measure the diameters of the large bowel and of the transverse colon and cecum, and if they are
Okay.
more
If
than
you have
6 or 9
something
cent.
abnormal at the sigmoid colon or rectum or
Yes, sir.
descending colon as well, if you have something like this and you couldn't do further contrast enhanced CT, but at least
Yes.
what can you do
Sir, I
at this?
can what sir, I can give the per rectal contrast,
Yeah,
and
rectal contrast. Okay.
yes,
Okay.
per rectal contrast
Okay.
can be done.
Let's give the patient rectal contrast. Really, we did rectal contrast. Okay.
Okay, okay, sir. Sir, so these are the per rectal
Okay.
contrast
Yeah.
images. Sir, I lost the control. I cannot scroll it.
Yeah. Yeah. Go ahead. Go ahead. You are scrolling now.
Okay, okay. No, sir, I think I have to ask you for the control again.
Okay.
No, no, no. Yeah, okay, okay. No, no, sir. Sorry, sorry. I'm scrolling it.
Okay. No problem. Yeah.
Okay, sir, sir. I'll again start looking it from the rectum, and
Okay.
then I'll scroll it further. So the okay, in the narrowing seen previously, I cannot appreciate it in this, and
Yeah.
however, the entire colon is dilated, and
Yeah.
I
Can you
will.
please stop here? You couldn't identify the obstructing lesion at the sigmoid colon
Yes, sir.
after rectal enema
Yes, sir.
procedure. Is that correct?
Yes, sir. Sir, can I have a
Can you
look at
please
it
go
again?
ahead? Yeah, go down, please, to see this rectosigmoid colon. I think, yeah, nothing. We don't have the obstructing lesion. We don't have the transitional point. Is that
Yes,
correct?
sir. Yes, sir. It's
Really,
gone
after
now.
doing this exam, the patient was much improved. The obstruction is totally
Yeah.
improved because, yeah, we did the CT diagnostic and therapeutic really at the same time. What do you
Okay,
think
sir.
this lesion could be?
So these could be impacted fecus or
Yeah,
fecolids. Yes,
very
sir.
nice. Okay, it's impacted fecal matter.
Yes, sir.
Okay,
Yes, sir.
what else should we do?
Uh, Sir, we
I'm
should
talking. I'm
also.
talking. I'm discussing with you. You did very well.
Yes, sir.
If you return back again to the, if we return back, this is a characteristic. I'm sorry. We have, yeah, this is
Sir, in the
a
noun
characteristic
contrast.
appearance of the fecal matter, high
Yes, sir.
density
The air high
with gas
density and along
locules
with the
inside. Yeah, and
motile
this is the
senses. Yes, sir.
transitional point. We don't have any extrinsic soft tissue process or something like this. I think this is the classic features of impacted fecal matter. It's
Yes,
relatively
sir.
common, but we need to get more extra findings in this case. Can we check the whole scan, please? May be helpful for you.
Sir, sorry, can we check what?
Can we check the rest of the exam?
Oh, yes, yes, yes.
Can we check the chest?
Yes, sir. Sir, we will go through rest of the scan as well.
Okay.
And
Can we go to the chest, please?
yes, sir, I'm going towards the chest.
We have gallbladder stones,
Yes, a
as you
gallbladder
see.
stone
Okay, but
and
go
sir,
ahead. Go
some
ahead. Yeah, go ahead.
layering hypertensity in the
Okay,
gallbladder as
okay.
well.
To save your time and save the time for the whole audience, can we check the lung, please? Yeah.
Yes, sir. The esophagus is patulous and dilated,
Yeah.
and
Very nice. Okay.
so the gastroesophageal junction is grossly unremarkable in this confinement, and I would like to review the lung windows as well.
Okay. Let's go to the lung window. Just a minute. Okay. This is the lung window.
Okay, sir. In the lung window, I
Can
can
we?
appreciate that there
Can
are
we? This is a lung
yes,
window.
sir.
Go ahead.
Yes, yes, sir. In the lung window, I can appreciate that there are changes of septal thickening with classical subpleural sparing
Yeah.
is noted, and subpulmonary fibrotic changes are noted with few intervening areas of ground glass haze are seen.
Mm-hmm.
So this is likely interstitial lung disease pattern NSIP with patulous esophagus, which is concerning for which is representing scleroderma in this
Very
case.
nice. Very nice.
Yes.
Let's conclude. What did you say? We have here coarsening of the pulmonary interstitium, as you see here. We have coarsening of the pulmonary interstitium. We have distortion of the lung parenchyma by coarse interstitial reticular infiltrates. And these reticular infiltrates associated by tubular cicatricial bronchiectatic changes, more
Yes,
pronounced at
bronchiectatic.
the middle lung loop. Yeah.
Yes, sir.
And more pronounced as the basal lung segments mounting to form cystic honeycomb changes. So
Yes.
once we have something like this, we will think of interstitial lung diseases, usual interstitial pneumonitis, and inshallah, once we start the chest cases, once you have something like this, we have some tips or few points you should check. One of these points, esophageal dilatation, and as you said, we have esophageal dilatation with interstitial lung disease. How can we link these findings? We have a possibility of scleroderma, and indeed, this is a case of scleroderma, and indeed, scleroderma cases has high risk of fecal impaction
Yes.
and
Okay, sir.
bowel obstruction because of impaired motility of the bowel loops. Yeah,
Yes, sir.
and also one of the GIT manifestations is zooted secretions of the bowel loops. But we have here a classic case of scleroderma. And once we introduced the rectal enema contrast, the fecal impaction was dissolved and bowel obstruction was totally resolved. Thank you so much.
Thank you, sir. Thank you so much.
And thank you. Candidate number 3.
Hi, good evening,
Candidate
sir.
number 3. Yeah, how are you, candidate number 3?
I'm good. How are you, sir?
Alhamdulillah, fine. Alhamdulillah. We have a nice case for you. If we start to scroll, really, I will give you the story for this case. This case presented by acute abdominal pain, and the patient went to the ER, and one of the ER doctors told me to do CT scan for the patient, but unfortunately, the CT machine was not working at the time. So we did for her MRI scan. And by the way, sometimes in your exam or in your daily routine practice, you can find the challenging point is to diagnose the case by the non-ideal modality. Okay, so let's take care of this point, and this is one of the classic examples for this scenario. Okay, go ahead. This is the locator. This is what happened with us, really. Okay, can you scroll the locator if you want?
I try to request the remote
Okay.
control.
Okay.
Okay.
Yeah,
Okay.
go ahead.
Okay. Okay. So maybe I see okay, that's the MRI pelvis in the coronal coronal sequence.
Yeah.
Okay. Sorry, there appears to be a cystic lesion in the pelvis. Sorry, multicystic lesion in the pelvis.
Mm-hmm. Mm-hmm.
Mm, at the I think at the area of the urinary bladder.
Mhm. Do you think
Close
that this one is, I'm sorry to disturb you. Do you think is this one, can I take the control, please?
Yes.
Yeah, okay. Do you think, I think this is a urinary bladder? Okay.
Okay, is the bladder.
Okay. Yeah, what is this one?
It's above the bladder. It's it appears round, well-defined, multi-cystic.
Okay. Can we check the coronal plane? Maybe
Okay.
helpful for you. Okay, go ahead if you want to scroll.
Okay. Doctor, do you mind to scroll for me? Sorry.
Okay, no problem. I will scroll for you. Okay, خلاص. I will
Okay.
take the hand. Okay.
So I believe it looks like loops of bowel.
Yeah,
They're
very nice.
There's scoliosis. Otherwise, no dilated loops of bowel.
Are these bowel loops small bowel or large bowel?
Due to its central location,
Yeah,
believe it's small bowel.
it's small bowel. Yeah. Okay.
And mm, the okay, they
Where is
appear
the large bowel? I'm sorry to disturb you. Can I take the control, please? Can I take the control of the mouse? I'm sorry.
yes, go ahead. The large bowel is not well.
Is this
I
one
think
small bowel or large bowel?
I think the collapsed one are the large bowel. Yes, the one that is
This is a large bowel. This is a large bowel. Do you agree with me?
Yes.
And as you said, we have dilated small bowel loops. Is that correct?
Okay.
Okay. So what should you do next?
Let's see in the axial cuts, perhaps.
Okay. Okay. This is the axial cuts.
Okay.
You will zoom on these axial cuts, and if you want to scroll by yourself, go ahead.
Or maybe doctor can help me to scroll.
Okay,
sorry.
okay, I will help you. No problem. Okay.
Okay, so coming from the rectum, pelvis area. So small bowels are seen in the pelvic area.
Yeah.
They're dilated, fluid filled.
Yeah, you are right. Yes.
But no signs of contrast extravasation. No leak. No.
Okay. We didn't give the patient any contrast, but this is a normal fluid signal. But yeah, because there is a stagnation of the fluid inside the small bowel, inside the dilated small bowel loops. We have also air fluid levels.
Okay, so I'll try to look for a transition point.
Yeah, very nice. Okay, so you are suspecting internal obstruction?
Yes.
The small bowel obstruction, because the rectum and the large bowel was not dilated. Okay.
Also on the left inguinal region.
Very nice.
What is that? There's a hernia?
Yeah.
Herniation?
Yeah, we have a left side groin hernia. Which type is hernia? Is it related to this bowel dilatation?
Yes, I'm able to see the bowel in continuation. So small bowel. This hernia contains a small bowel
yes.
and omega.
Yes.
And appears to be narrow at the orifice, narrow neck. likely causing the dilated small bowels.
This is the axial stair.
Okay, in the back set, sorry, axial stair. There's also surrounding edema.
Yes,
sorry,
you are right. Okay. So your final diagnosis?
Small bowel obstruction, secondary strangulated hernia, strangulated left inguinal hernia, or
why did you say strangulated hernia?
Or sorry,
yeah, you are right in your thinking, but how can you detect the strangulated hernia? You went into a difficult point in discussion. Yeah. Okay. So okay, let's conclude, or let me ask you the most important question here. Which type of hernia? This one. We have left groin hernia, and left. Is it inguinal? Is it something else? What do you think?
I think it's inguinal.
Inguinal hernia.
Inguinal hernia.
Okay. Okay. I'm happy, because I think you got the diagnosis, but just I would like to modify some points. We have here left groin hernia, and once we have left groin hernia, we should draw a line from the pubic tubercle. This is the site of pubic tubercle, and we will make a line like this one, okay, and we will make a line also at this point, okay. And let me ask you, if we have a hernia here, totally in this compartment, lateral to the pubic tubercle, this is the location or exact location for the direct hernia. If we have the hernia here, part of this lateral and part of this medial, but the predominant or the larger size of the hernia is medial to the line of the pubic tubercle, we have here indirect hernia. If we have the hernial sac, the larger part of the hernial sac down to this line, it's lateral to the pubic tubercle, but inferior to this line, so most likely femoral hernia. But I would like also to tell you something more important than this illustration. If you have any mass effect on the femoral vessels, especially the femoral vein or indentation of the pectineus muscle, so for sure this is a femoral hernia. If you compare here, this is the pectineus muscle on the right side, this is the pectineus muscle on the left side. As you see here, we have slight indentation of the pectineus muscle. Do you agree?
Yes. Yes.
So this is a femoral hernia. If you find the femoral vessels itself, here the femoral vessels, are displaced posteriorly, so you are dealing with a femoral hernia. Last point to differentiate. Yeah, last point to differentiate is difficult in the MRI. I think it will be more easier in the CT. Here we have the rectus sheath and rectus muscle, and this is the site of the inferior epigastric artery. It's coming from the external iliac artery. If we have the hernial sac lateral to this artery, so we have indirect inguinal hernia. If we have a hernial sac projecting medial to this artery, so we have direct inguinal hernia. If we have a hernial sac inferior at the inferior level to the inferior epigastric artery, so we have a femoral hernia. So we have 3 points to differentiate. Also, the inguinal hernia can be seen in multiple slices, but the direct inguinal hernia can be seen on 1 or 2 slices. And anyway, we have many different points to differentiate, but this is for sure we have femoral hernia with displacement of the femoral vessels posteriorly. Okay, let's go. So this is the site or the cause for a small intestinal obstruction. But we need, if I want to report this one, so I have a small bowel obstruction secondary to obstructed left side femoral hernia. I can say obstructed, or I can say incarcerated femoral hernia. I couldn't say strangulated.
Oh,
Incarcerated means irreducible hernia. It's a clinical term, but we have some findings radiologically that can suggest incarcerated hernia. Okay, incarcerated hernia, if you want to say incarcerated hernia, you should see surrounding soft tissue edema, dilated bowel loops, narrow neck at this point, and also sometimes if you find slight mural wall thickening. Okay. Incarcerated means irreducible or obstructed hernia. Okay. The term strangulated hernia, that means that you have super added ischemic changes. Okay. If you want to say strangulated hernia, you should do contrast enhanced study, either CT or MRI, and check the contrast enhancement of the bowel loops. If it is hypo enhancing, so you are suspecting strangulated hernia or ischemic bowel changes. Okay, so those are the most common complications for this one. So we have here small bowel obstruction secondary to obstructed or incarcerated left femoral hernia. Okay. Okay, thank you so much. Candidate number 3. Can we go to candidate number 4?
دكتور بعد
Yes,
اذن
sir.
حضرتك معلش ممكن سؤال في الحاله
نعم.
اللي فاتت دي
اتفضلي يا فندم.
معلش الهوريزونتال لاين اللي كنت حضرتك رسمه من شويه كان
أيوة.
هو بينترسكت ايه
هو
بالظبط؟
ده بالظبط ده البيبك tubercle. لو في السي تي
تمام.
in the CT it's easier to identify that pubic tubercle at this site, at this location. Okay.
اوكي
The line there is 2 lines, one perpendicular to the pubic tubercle and one parallel to the both pubic tubercles. Okay.
اوكي دكتور شكرا يا دكتور.
Okay, thank you. Can we go to candidate number 4? Are you ready?
Yes,
candidate
sir.
number 4. Okay.
Yes, I'm ready, sir.
Okay. We have a pediatric patient complaining of abdominal pain. If you want to scroll, go ahead.
Yes, sir. I have requested the remote control.
Go ahead.
Okay. Okay, so I have been provided with the CT abdomen of a child, axial sections with non-contrast and only having oral contrast. I will start from the top sections and then I will scroll down. Okay, so the lung bases appear grossly normal. There is no enlarged mass on the mediastinal window. The liver, the spleen, and the pancreas on the limitations of non-contrast appears normal. The stomach is partly air distended without any abnormality. The kidneys also appear normal. I'm scrolling downwards.
Yes.
The small bowel loops are contrast specified, mostly the left-sided bowel loops.
Okay.
And I can see that there is a thickening of the large bowel loops. On the right side, the cecum appears significantly thick-walled with luminal narrowing, and there is minimal surrounding fat stranding and reaction. I am scrolling upward to see the ascending colon. The ascending colon also appears mildly thickened with surrounding fat stranding. I am looking at the transverse colon, which appears relatively preserved, I guess. So there is significant stranding and wall thickening on the right-sided colon. I would ask for any history of chemotherapy or any
can I show you the contrast enhanced study, please?
Yes, sure, sir, sure.
Okay.
Sir, I'm scrolling downwards to look at the right-sided colon. I'm scrolling downwards. So the transverse colon is dilated, but it's not significantly thick-walled compared to the right-sided ascending colon with significant luminal narrowing. This is giving typical accordion sign only on the
Yes.
right-sided colon. So
Yes.
there are two main differentials. I would ask for the history of any neutropenia. If there is neutropenia, it will be a neutropenic colitis. Other differential would be a pseudomembranous colitis. These are the two main
Amazing.
differentials.
Yes, you are right.
Yes,
You are right. You are
so
totally right.
yes,
Can I stop you here, please?
yes.
You
So
said that we have circumferential neurothickening and second edematous haustra, and this haustra making like accordion sign. And I think it's better to see it in the coronal plane. Look for this haustra and the mucosal edema and submucosal edema, and it's involving the ascending colon till the hepatic flexure, and we have a dilatation of the transverse colon. Let's measure this one. I think it's 3.3 centimeter, but we need to take care of this one because of possibility of toxic colon, and the need to be followed up by X-ray abdomen. And as you said, the most two differential diagnosis in this case, pseudomembranous colitis, Clostridium difficile, and also the neutropenic colitis or typhlitis.
yes,
According to the history, if the patient is immunocompromised, we will think of typhlitis or neutropenic colitis. If the patient is if the patient received a long history or long intake of antibiotic therapy or chemotherapy, and this is what the patient was received. The patient was received long-term history of antibiotic therapy for more than 5 weeks. So it's complicated by pseudomembranous colitis. And this one should be managed conservatively. I think also we don't have any perforation, we don't have any pneumoperitoneum, we don't have any mesenteric vein occlusions. Also, I would like to say, is it ischemic? Because yeah, our differential ischemic infection, inflammatory. I think it's
sir,
difficult to be ischemic at this age group.
yes,
Do you agree?
yes, sir. Sir, the mucosal enhancement pattern appears
Yes, the
normal.
mucosal
There is no
enhancement. You are
significant.
right. You are right. We don't have hypoenhancement. We have edema, and the mucosal enhancement is preserved. Okay. So we have here, look for this one. This is the accordion sign that I want to tell you. I'm sorry because the pen is not working with me today, but this is the accordion sign. Okay. Thank you so much. Candidate number 4.
Thank you, sir.
Can we stop here? Can you see this line? Okay. As we said in many times before, that we have chronic thumbprinting or chronic mural thickening. We are thinking for infection, inflammatory, ischemic, or iatrogenic. We discussed this point in many previous VIVA sessions, and this is the right-sided causes, transverse colon causes, and left-sided causes. Left side include diverticulitis, appendicitis, inflammatory ulcerative colitis, ischemic colitis from the spleen flexure to the sigmoid colon, infection, or iatrogen. Okay, and we have also abdominal pain.
Okay. Yeah, I have been provided with CT with intravenous contrast in the portovenous phase.
Okay.
Yeah, I see like some smudging of fat within the left epigastric region.
Okay.
Yeah, and the bowel loop seems dilated, small bowel dilated.
Yeah.
I would like to see the point of transitions within this left. I don't have any evidence of ischemic reason, like the vessel is well opacified, no free fluid or free gases should be identified.
Okay. Yes, totally agree.
Yeah.
I think you got a very important findings.
Yeah, for this smudging of fats and
smudging of fat.
Yeah,
at which side?
mild at the left epigastric region or
Left lumbar region.
Yeah, left lumbar.
Okay.
Yep. But I can see the reason why this area is infected
Okay.
like that or inflamed like that, localized inflammation.
Okay.
Like there is no swirls of fat or evidence of volvulus.
Okay. Can you please
Okay.
check the anatomy of the bowel loops?
Okay. So we start from the stomach upside.
Stomach. Okay. This is the
Yeah.
stomach. Okay. If you want to, this stomach, and this is the
It's
duodenum.
the duodenum, yes.
Okay. The
Straight
duodenum.
coming down.
This is the third part of the duodenum.
Yeah,
And
exactly.
where is the duodenojejunal junction?
Yeah, it's on the left side. There is
It is on the right side.
Yeah, sorry, on
It
the
doesn't
right
cross the
side.
mid. Yeah, it doesn't cross the midline.
Yeah.
Is that
Yeah.
correct? Okay.
Yeah,
Very nice.
exactly.
Okay.
Yeah.
Agree.
Yeah.
Okay.
So there
So
is
where is the small bowel?
malrotation. Yes, this is malrotation. Most of the small bowel in the coming
Very
on the
nice.
right side.
We have the small bowel located at the right side,
Yeah.
and the large bowel is located at the left
On
side.
the left side. Yeah.
And also we
And
have
this.
the inverse relationship. Once you have something like this, please go ahead to check the mesenteric vessels. So this is the superior mesenteric artery, and this is the superior mesenteric vein. We have inverse relationship between the artery to the
and
vein.
vein, yeah.
The artery should be at the left side to the vein, but this is inverse relationship. So we have something like malrotation, and this one is called non-rotational anomaly or non-rotational anomaly of the small and large bowel, and this is considered a form from intestinal malrotation. Okay, so now I think it's easier now to check again. What is this structure?
This is I think this is part of the small bowel.
Do you think?
Yeah.
So can we scroll from down?
Yeah, it's large.
Can we scroll from down? Yeah, we have here the rectum, sigmoid colon, descending, and splenic flexure, and this is the transverse colon, and the transverse colon is going here, and this is the ascending colon, and this is the ascending colon, and this is what is this one? Cecum.
Yeah, the cecum.
Okay.
Yeah.
And what is this?
The appendix.
Yes, you're right.
Yeah, dilated appendix.
Dilated appendix and surrounded by smudged fat planes. So we have a case of
acute appendicitis, but on
acute
the
appendicitis.
left side.
Yes, you are right. Left side. Very nice.
Yeah.
We have a left-sided acute appendicitis. Yeah. The tough point here is to check the anatomy first. Okay.
Yeah, to know
Once you check the anatomy, you will easy find the diagnosis. Really, I saw it once in my life. Okay.
Yeah, it's very nice.
Not
case.
so common, but really, it's once you identify the anatomy, well, you can find this one. And especially in the exam or FRCR exam, you will find many examples like this one. He will not give you the acute appendicitis straightforward acute appendicitis. He can give you acute appendicitis with complication. He can give you acute appendicitis on top of abnormal intestinal orientation. Okay, so this is a left-sided acute appendicitis. Thank you so much, candidate number 5. Thank you so much. Can we go to candidate number 6?
Yes, sir. I'm here.
Okay, go ahead. Candidate number 6, acute abdominal pain.
Okay, I'm presented with X-ray abdomen frontal projection of a skeletally mature patient who presented with acute abdominal pain. I can see that there are multiple dilated bowel loops occupying whole of the central abdominal cavity.
Okay.
And also in the pelvic region.
Yes.
I can see there is suspicion of the regular sign. However, there is no cross pneumoperitoneum. But in my
Okay.
routine practice, I will like to go for the decubitus views or the erect chest X-ray to rule out pneumoperitoneum.
Very nice. I think you got
And
the idea that I want you, or the message that I want you to know. So we have here, as you said, we have diffusely dilated bowel loops involving the center of the abdomen. So we have dilated small bowel loops, and also we have dilated large bowel loops. Look for the sigmoid colon and rectum. So we have a diffusely dilated small and large bowel loops, and on top we have an evidence of pneumoperitoneum. We have different signs of pneumoperitoneum. We have here subphrenic gas lucency. We have a regular sign, very clear. The
yes,
serosal surface,
yes.
the outer aspect of the serosal surface of the bowel loops, you shouldn't see more defined wall like this one. Once you can see a well-defined serosal surface of the bowel loops, so you are suspecting air outside and air inside. Air outside pneumoperitoneum, air inside the normal air inside the bowel loops. So you can see the wall of the bowel loops very clear, easily identified. So this one is called regular sign. And also we have a triangular sign, gas sign, telltale sign. And so we have a different signs confirming that we have a pneumoperitoneum. And this case was operated and they found small bowel loop perforation on top of Crohn's disease. And this dilatation is considered as ileus for this perforation and pneumoperitoneum. Okay, so we don't have a mechanical obstruction, but we have here non-mechanical obstruction. Okay, remember this point, okay, because we will discuss this point later on. Okay, stay with me. Candidate number, you are candidate number 6, okay, is that correct? Okay, as you said, once we have any suspicious of pneumoperitoneum, even in your exam, please go ahead into the left lateral decubitus to check the pneumoperitoneum. If it is non-gravitating below the liver shadow, I think it will confirm an evidence of pneumoperitoneum. Okay, so you can say this one on your exam. Okay, if you are in doubt, you can ask to do left lateral decubitus. Okay. Okay, what can you see here? Candidate number 6.
Okay, I'm presented with X-ray abdomen frontal projection of a skeletally mature female patient. Here I can see that there is a paucity of the bowel gas shadows in the abdomen. However, I can see that there are few air bowel gas shadows seen in the central abdomen, giving the string of
Okay.
pearls appearance. And there is
Okay.
also a few of them showing the air fluid levels, especially on the left side
Okay.
of the abdomen. Yes, and I do not see any air under the diaphragm, and I will like to correlate with the history of the patient.
Abdominal
Otherwise,
pain, acute abdominal pain.
Appearance of the string of pearl sign with a small
Yeah, you're right. String of pearl sign. What does it mean?
appearance. It means small bowel obstruction,
Yes,
and
you
I
are right.
also
Very
proceed
nice.
with the
Okay.
contract enhanced CT abdominal
Yeah,
pelvis.
if you can here localize, if we can focus here, we have here like gas pockets in a linear fashion, as you can see in this X-ray. You will find gas pockets in a linear fashion, and this one means string of pearl sign زي كده السبحة، يعني حاجات العنقود كده بتاع السبحة. ف it means that we have a small bowel obstruction, and please don't be confused by the case that we saw in the previous session, pneumatosis intestinalis. Pneumatosis intestinalis means that we have a gas, intramural gas, inside the wall. But this gas is gas entrapped between the vulva connivans of the small bowel loops, okay, because of intestinal obstruction. So this gas is entrapped gas between the vulva connivans. It's not intramural, it is intraluminal, but entrapped between the vulva connivans, okay? So that, yeah, this sign indicates that we have indeed small bowel obstruction. Thank you so much, candidate number 6. Can we go to candidate number 7?
Assalamu alaikum, sir. I'm candidate 7.
Wa alaikum salam. Candidate number 7.
Yes.
Okay.
Okay, sir. Sir, I'm provided with an CT scan of an adult patient in which
Yes.
these are the photovenous spaces. I can appreciate this bowel dilatation is noted. Small bowel lobe surface significantly dilated and mild free fluid also noted within the abdomen. Sir, I can appreciate the stomach. Sorry, yes, sir. Sir, I can appreciate this. The telescoping of a bowel is noted. I think this is a large bowel at the level of the transverse colon.
Yes.
Yes, sir. I can appreciate there's a large segment of a large bowel is seen telescoping within the another segment, which is giving, I think this is an ascending colon. Sorry, ascending colon, which is seen telescoping within the transverse colon, giving coloniocolonic intussusception.
Okay.
And also, there are fat density identified within the transverse colon. Yes, sir. So this may appear as a lead point which lead to this colonic intussusception and leading bowel dilatation. Yes, sir. Sir, in my routine practice, I also want to check the lung window to see any perforation.
Okay.
But there's a significant fat standing is identified. So there is a proximal segment of significant dilated cecum is noted. Iris fecal junction is fine. So, sir, this is a case
your
of
conclusion?
So, this is a case of a colonic intussusception, which is leading to all bowel dilatation. Also, the wall of the intussusception shows preserved enhancement. It is not an strangulated type, but it is
very nice. Very nice.
And
yes.
There is, sir, I think the lead point is some bowel lipoma or any fat density.
Very nice. Very
which
nice.
may lead to this
you did very well, candidate number 7. As you said, we have here, I like to describe the intussusception by 2 terms. Either you can say invagination of the chronic bowel segment of the ascending colon inside the transverse colon, or you can say telescoping or invagination. Okay, those are the most simple terms to describe the intussusception. As you said here, once we have intussusception, if we have a case or pediatric case, the cause can be lymphoid hyperplasia. This is the most common cause. But in adult age group, if we have a case of intussusception in adult age group, underlying tumor is suggested till otherwise. Okay, so underlying tumor, maybe benign tumor, maybe malignant tumor. So you should have a cause for the leading point. You should search for the cause. Here we have a very obvious intramural or submucosal lipoma of the invaginated bowel segment, and also this one is called intussusceptum, and this one is called intussuscipiens. That's the colonic segment receiving the invaginated bowel loops. Okay, so this is the leading point, intramural lipoma. Sometimes, in many cases, we couldn't identify the cause of the leading point, but this one should be managed, and we should search. Even if the intussusception was resolved, we should search for a leading point. You should do endoscopy and searching for the cause for this leading point. And as you said, we don't have any evidence of insane ischemia. We have a large bowel obstruction and also small bowel obstruction, mixed large and small. We have also free fluid collection. So this is a case of intussusception. Colonic intussusception causing small and large bowel obstruction. Okay, thank you so much, candidate number 7. Can we go to
بعد إذن
candidate؟
حضرتك ممكن لو في كورونا حضرتك توريه لنا بعد إذنك؟
لو كان في ايه فن؟
لو في كورونا فيلم
coronal. Okay,
بعد
okay,
إذنك.
okay. This is a coronal plane. Look for this one. This is lipoma, and this is, look for the mesenteric vessels. Look for the bowel loop here. The bowel loop and even the mesenteric vessels and mesentery going inside the transverse colon. Okay, with secondary marked dilatation of the cecum and dilatation of the small bowel lobes. Okay, we don't have any perforation. Thank you. Can we go to candidate number 8?
Yes, sir.
Okay, candidate number 8. Okay, abdominal pain.
Okay, this is the abdominal CT scan later study in coronal plane.
Yeah.
I can appreciate that there is multiple dilated loops of a small bowel.
Yes.
I want to scroll through to find and localize the transitional point.
Okay.
I can't appreciate any free air, pneumoperitoneum, any portal venous air in this available sequence.
Very nice.
And I want to check the hernial orifices as well.
Before searching for the transition point, you are totally right. Before searching for a transition point, what should you do first?
Radiologically speaking, or like clinically?
You should differentiate, is it small bowel or large bowel obstruction? Is that correct?
Oh, yes.
What do you think?
I think, yes, I believe these are like small bowel loops. They have
you are
like
right. This is the large bowel. Look for the
and it's appeared collapsed.
Collapsed. Very nice. Very nice. Okay. So you have here small bowel obstruction and you are searching for any transition point. I think it's difficult here in this clumped dilated bowel loops to search for any transition point. Let's go to the axial plane.
Axial planes. There is the right obturator hernia. I can.
Yeah, you are right. Very nice. We have here a very classic, straightforward case of obturator hernia between the pectineus muscle and obturator externus muscle. And this is the cause of the intestinal obstruction.
The upstream obstruction. It has an thickened wall, a thickened edematous wall. It could be due to an inflammation or an early strangulation, but there are no mural air within the herniated loops and no also entrapped fluid. Checking with the contrast enhanced study to assess the enhancements of the wall would confirm or exclude strangulation.
Okay, so you have a right sign, obstructed obturator hernia with secondary small bowel obstruction. We don't have any pneumoperitoneum. And as you said, if the patient is prepared, we should inject IV contrast to check the viability of the bowel lobes.
The pancreas, can I check the pancreas?
Okay.
Okay, the pancreas looks fine, but I can see there is mild intrahepatic biliary radicals dilatation and the CPD appears slightly dilated.
Okay.
I can't see dilated bowel loops, but this is a descending colon.
You are right.
The descending colon shows edematous wall.
Very nice.
With submucosal fatty infiltration. This indicates there is maybe chronic inflammations there. I can't see there's subtle fat stranding surrounding the colon. I will check down to the can I check down to the rectum?
Okay.
Okay, it seems that the inflammation is involving the rectum, sigmoid, and the descending colon as well.
So we have a mural thickening, circumferential mural thickening, smooth circumferential mural segment for a long segment, starting from this splenic flexure down to the rectus sigmoid. Okay, we have minimal fat stranding, and you said that we have submucosal edema. It's hypoenhancing. Do you agree?
Yes.
Okay. What's your definition? You said we have inflammatory
process.
Okay. Colitis, inflammatory. Okay.
Yeah. So this might be maybe ulcerative colitis. Maybe
acute phase. Okay. What else?
Maybe colitis or ischemic colitis, but I can't see that.
Ischemic colitis. Is that matching?
No, there is no. The enhancing of the wall is still preserved.
Okay, but we have submucosal edema.
Yes.
Okay, but
the mucosal
I want to tell you something.
Yeah.
This is the territory of the left colic artery from the spring flexure down to the rectus sigmoid. So
Yeah.
take care of this point because we have a segmental colonic mural thickening confined to the territory of the left colic artery. So ischemic colitis, one of the top differential diagnoses. Okay.
Okay.
Even I think it should be the first. I know that you couldn't identify any obstruction of the mesenteric vessels, but we said in the last session that we have non-occlusive ischemic bowel disease. Hypoperfused bowel segment can lead to ischemic colitis without any obstruction
But
of
I
the
can't see enhancement in the mucosa and the wall. Am I right?
Yeah, it's hypoenhancing. It's it's matching with ischemic colitis. It's hypoenhancing, and even the pericolic fat planes, it's not so much smudged. Do you agree?
Yes. It's not acute. It's not
Yes.
typical with acute inflammation or infection.
Acute inflammatory changes. Yes, you're right. But really, you should put it in your differential diagnosis because we should do lactate level later on, and we should review the history of the patient. If there is any history of recurrent acute attacks or ulcerative colitis or taking corticosteroid therapy for ulcerative colitis or something like this. Okay, but your thinking is very correct. You should suspect ischemic colitis. You should suspect inflammatory, also infectious disease. Iatrogenic, it's so difficult to be iatrogenic or radiation induced in colitis because I think it's not direct or it's not related. I think we don't have any primary tumor at this area, but you should check also if there is any radiotherapy before. But this is a long segment.
Long segment.
Post radiotherapy effect, it will be segmental. Yeah, in this case proved to be ischemic colitis.
Ischemic colitis. Okay, and I have to check also the vessels to rule out if there is any thrombosis or obstruction, which I can't see here.
This is the inferior mesenteric artery, and this is superior
mesenteric artery.
All of these are patent. Even the mesenteric vessels almost patent. Okay.
Yes.
Okay. Thank you so much.
Thank you, doctor.
You are candidate number 9? Or?
Yes, 9.
Okay, candidate number 10. Candidate number 10.
Assalamu alaikum, sir.
Wa alaikum salam.
Yes. Missed my number to 13. Sorry.
Okay. Candidate number 10. Okay, abdominal pain.
Okay.
This is a very interesting case and full of many teaching points.
Okay.
Full of many teaching points, really. Okay, go ahead.
Okay. Yes, sir. These are axial slices of the CT abdomen in a portal venous phase, in which I can appreciate that there is in the the right kidney shows no, I cannot appreciate the right kidney, and
very nice.
Okay. Yes, there are bowel loops that are in a close, which are dilated and show two transition points and are located in a close, not a membrane though, but yes, it's sort of a closed loop obstruction, and there is surrounding fat stranding, and the stomach is massively dilated. Liver and spleen are unremarkable, and the left kidney is normal, and small bowel is dilated with of pulse sign noted, which is suggestive of small bowel obstruction, and
very nice.
It is due to this closed loop obstruction.
Okay.
And
what is the cause? What is the cause for this closed loop obstruction? You did very well. What is the cause and what is the complications?
Sir,
you said that we have a closed loop obstruction, but you didn't mention
the cause. Yes,
the cause and even some complications that you can identify.
Sir, maybe there is some but I cannot see any ascites, so I cannot see any perforation. And however, there is massive fat stranding around this area that can be suggestive of inflammation and inflammatory cause. And the right kidney wasn't there. It can
the
be.
patient did the nephrectomy 10 years ago.
Okay. Sir, I'm not sure about the cause though. There is some, sir, there is swelling of the vessels here, and yes, so it can be some volvulus of the mesentery that is causing
Okay.
this small bowel obstruction.
Okay.
Sorry,
Why is this small bowel closed loop obstruction? Why this closed loop obstruction happened here at this location?
Sir, because of the absence of the kidney, I guess.
Yes, you are right. Because of the nephrectomy bed. Because this is a herniated bowel loops into the nephrectomy bed. You are right.
Yes, sir.
Okay. So this is a cause, as you said, and you said that you mentioned that we don't have any perforation.
Yes, sir. Sir, I cannot see any ascites, but there is fat stranding and inflammation in the vicinity. Yes.
Okay. What else?
Sir, I can appreciate that the vessels are
once you have closed loop obstruction, you should say, or you should search for complications. You said perforation. What else?
Okay. Sir, ischemia of the.
Yeah, you are right.
Yes. Sir,
do you have any ischemic bowel segment inside the
sir,
the obstructed bowel segment?
Yes, sir, but these look okay to me. The wall is enhancing properly.
Okay.
So I cannot
Properly,
appreciate
do you think?
Is
there any bowel wall thickening?
Yes, sir. Bowel wall thickening is there.
Yes, we have thickening, and also as compared to the normal bowel, I think it's
a little
this
bit
is a normal
less
enhancement.
Yes,
it's hypo enhancing, and we have a mural wall thickening. So we have
some element of ischemia.
A potential element of ischemic bowel.
Okay. Yes.
Disease. Yeah. So again, as you said, you did very well, really. We have here a closed loop obstruction, and the closed loop obstruction really, I saw it many times. So you should know what is closed loop obstruction. Closed loop obstruction means that
there are two transition points.
Yeah, you are right. We have two transition points. We have here dilated bowel segment in the form of C-shaped configuration, and pointed at one point here. We have here transition point. Look for these dilated bowel loops upstream. Dilated bowel loops, and this one is going here, kinking of the bowel towards these dilated bowel loops. So we have here the first transition point, and also we have here the second transition point here to the collapsed bowel loops distally. So we have two transition points very close to each other, and we have dilated bowel loops, radial configuration or C-shaped configuration. We have also mesenteric edema.
Yes.
And mesenteric vessels engorgement and mild or minimal free fluid collection. Yes. So we have case of closed loop obstruction. This is considered one of the emergency situations.
Yes, because immediately refer the patient for surgical opinion and open loop laparotomy.
Yeah, you are right. There is a high risk of strangulations and bowel ischemia because we have two causes of the ischemia here. Because we are at transition point.
Yes, sir.
Yes, and also the dilatation itself making hypoperfusion of the bowel loops. So we have high risk of ischemic bowel changes. Okay. Thank you so much. If you want to see the coronal plane, I think it's very easy to see the closed loop obstruction.
Yes.
Okay. Thank you so much.
Thank you so much, sir.
Can you?
Thank you.
Yeah,
yes.
I just have a question. How to differentiate this is from hernia, not from adhesion?
Okay, let me, let please keep with me till the end of the session, because I will describe, or I will discuss with you how to differentiate, what is the approach to diagnose bowel obstruction. Okay.
Okay, thank you.
Okay, welcome. Okay, so this is the criteria of closed loop small bowel obstruction. Big sign, you will find two big signs because we have two transition points and sharp angulations of the mesenteric vessels, radial distribution or U or shape configuration of the closed loop bowel. You can see also the volvulus or twisting of the mesenteric vessels or swell sign. Also, you can see mesenteric edema, intramural hemorrhage because of stagnation and venous congestion inside the wall of the small bowel loops. Those are the features of closed loop small bowel obstruction. Okay. Okay. Next candidate. Candidate number
Yes, sir.
11. Is that correct?
Yes, sir. I'm here. Yes, sir.
Okay.
I am here.
Candidate number 11. Candidate number 11. Abdominal pain.
Okay. So I have been provided with the X-ray abdomen frontal projection of a female patient who has presented with abdominal pain, and I can see that there is a dilatation of the large bowel loop in the region of the transverse colon is appreciated. And
Is it large bowel or
can't.
small bowel?
Sir, it is within the center of the abdominal cavity, and yeah, there are multiple valvulae conniventes also seen.
Yes,
So
you are right.
yeah, I am
This
concerned
is
for the
valve
small bowel
connivence.
obstruction.
Yeah,
Yes, sir.
coin stick appearance. So
yeah. So
okay.
and I am looking for any free air within the abdominal cavity.
Okay.
I can't appreciate in this image because I can't see the upper extent of the abdominal cavity. So I would like to have a look at in the subdiaphragmatic regions as well. And I am trying to look if there is any evidence of any hernia or any calculus.
Yes, you are right. We don't have any hernia or obscene. Yes.
Okay, so and I can see visualized bones, they appear normal. Few degenerative changes are noted within the visualized hip joints. And so
what's your next step?
Next, I would like to do the CT scan abdomen with contrast to look for the cause of the obstruction. Yeah, so this is the CT scan abdomen with contrast axial sections in which I can see that there is marked dilatation of the small bowel loops noted, both the jejunal and the ileal loops. And there is, although I can see that the enhancement of the wall is preserved, there is hyperdensity focus appreciated within the bowel loops here. So I am concerned that there is an impacted stone here, which is causing the upstream dilatation, because after that there is marked change in the caliber of the bowel
Very
loop.
nice.
I
Very
can
nice.
also appreciate there are air densities within the biliary channels, and, that signifies the pneumobilia. But I am trying to look for gallstones, but I can't see it. Although I can appreciate the fluid in the region of the gallbladder fossa. So if I combine these findings, like the calculus within the bowel wall, small bowel dilation, and the air within the biliary channel, so this is the Riggler's triad. So I would immediately inform my findings to the referring physician, to the emergency department. Because it is an emergency and it needs urgent exploration. I also appreciated some hernia within. Yeah, there is hiatal hernia.
Yes, Heights hernia, large Heights hernia.
Yes,
Okay,
yes,
right.
there is hiatal hernia as well.
Okay.
So
your final diagnosis?
So is the small bowel obstruction due to gallstone? This is the gallstone ileus.
Okay, yeah, you are right. So you have here gallstone ileus, very small stone, and we have secondary small bowel dilatation, and also we have some sort of fistulous communication between the gallbladder and the duodenum. This is colitis to duodenal fistula. This is the pathway of the gallstone to drop from the gallbladder into the bowel loops and obstruct the bowel loops at different segments. Also, we have gas pocket inside the fundus, inside the neck of the gallbladder. Also, we have here pneumopelia. We have the triad of gallstone ileus, pneumopelia, bowel dilatation, and the stone. So we have the triad of small bowel obstruction secondary to gallstone ileus. If we return back to the X-ray, it's hardly to see this small shadow of gallstone ileus. I think it's difficult to identify this one. It can be identified retrogradely. It's very, very, very difficult to imagine that this one is gallstone ileus, but I think you did very well. We have a case of gallstone ileus. Before going to the next case, can we discuss together?
Yes, sir.
Small bowel obstruction can be classified into many different ways. Okay, we can differentiate, or we can classify small bowel obstruction into mechanical and non-mechanical. Mechanical means organic obstruction. Non-mechanical, as we saw in one of our previous cases, small and large bowel dilatation without obstructing cause. It can be secondary to previous surgery, electrolyte imbalance, and something like this. We have also small bowel obstruction can be classified into complete or partial. Partial if the enteric fluids or enteric contents can bypass the obstruction. We have high grade and low grade. Take care of this one. High grade small bowel obstruction and low grade small bowel obstruction. High grade if we have small or long segment of feces, sign, and ascites, and low grade if we don't have any of these signs. We will see in next case. We have also classifications of small bowel obstruction, non-closed loop bowel obstruction, or simple obstruction, or closed loop bowel obstruction. Also, we can classify the small bowel obstruction into complicated and non-complicated. Complicated bowel obstruction, we have two main complications: bowel ischemia and bowel perforation. So, in your opinion, in any case of bowel obstruction, you should say, is it complete or not? You should check first, is it mechanical or not mechanical, complete or partial, high grade or low grade, simple obstruction or closed loop obstruction, complicated or not complicated. So you should mention these points in your opinion, okay? We have different causes for small bowel obstruction. To memorize yourself, you will find luminal causes, mural causes, extrinsic causes, okay? Inside the lumen, gallstone ileus, fecal impaction, foreign body. Mural, if we have any stricture of the bowel loops, if you have any mass, either primary or secondary. By the way, the secondary causes or secondary malignant causes like metastasis, most likely from the breast or gastric metastasis. Also, the intussusception, one of the, I consider this one as a mural cause. You can put it inside the luminal causes. Extrinsic cause is very important. And the most common cause for small bowel obstruction is adhesion. Okay. Second, we have under extrinsic causes hernia, obstructed or incarcerated hernia. We have volvulus. We have also peritoneal masses from the outside can cause small bowel obstruction. Adhesion is the most common cause for small bowel obstruction. And sometimes, or if we have closed loop obstruction, those are the three causes that can cause small bowel obstruction: adhesion or adhesive band, hernia, especially the internal hernia. Okay. As we saw in one of our previous cases, nephrectomy bed, we have internal hernia inside the nephrectomy bed, and volvulus. Those are the most common causes for closed loop obstruction. But does that mean that all the adhesive bands cause closed loop obstruction? Only no. We can see adhesive band with one transition point. This is not considered as closed loop obstruction. Okay, is that clear? Okay. Let me focus again in stricture, because you should know what is the cause of stricture is inside the small bowel loops. The small bowel stricture, I have different categories: either infection, inflammatory, TB, and Crohn's, ischemia, chronic bowel ischemia, iatrogenic, radiation or non-steroidal anti-inflammatory drugs, neoplastic causes, primary and secondary, carcinoid, miscellaneous, endometriosis, extrinsic causes, including carcinoid. The most common is Crohn's disease, and chronic bowel ischemia is less common. Also, we have some extrinsic causes like carcinoid tumor. Carcinoid tumor can make like a desmoplastic reaction around the mesenteric mass and can cause bowel stricture. The small bowel obstruction in the pediatric age group, the cause is totally different. Okay, so in adult, it's different than pediatric age group. Pediatric age group, we have 6 main causes: appendicitis, it's very common; adhesion, intussusception, incarcerated hernia, mid-gut volvulus, Meckel's diverticulitis. Those are the top 3: appendicitis, intussusception, mid-gut volvulus in the pediatric age group. My mnemonic name here is 2 times IM, AA, II, MM. We have also luminal causes, but it's very rare. Okay, so those are the top causes for the small bowel obstruction in the pediatric age group. My approach to diagnose small bowel obstruction first excludes the non-mechanical bowel obstruction. If we have a dilatation for small and large bowel, and we don't have diffusely dilated small and large bowel, and we don't have an organic cause or obstructing lesion, you should check with the clinical. Did we have any previous surgery? There is any erythrocyte imbalance, something that can explain the non-mechanical bowel obstruction or paralyticus. Okay. Second, you should differentiate between small and large bowel obstruction. Ask yourself, is it small or large bowel obstruction? Try to identify the site of the transition. So we have a small bowel obstruction. Try to identify the site of transition between the dilated and collapsed bowel loops. Dilate bowel loops more than 2.5 or more than 3 centimeters. We said this one in the previous session. If we have 2 transition points, so you should think of closed loop obstruction. If we have 1 transition point, you should think of adhesive bowel obstruction or something like this, okay? Or simple bowel obstruction. I want to say also, sometimes for the juniors, it's difficult to identify the transition point. Please trace either the dilated bowel segments to get the transition point, or you can trace the collapsed bowel segment to get the transition point, okay? Try both of these ways, okay? Also, I have a message here. If you didn't get the transition point, you should exclude the other causes of the intestinal obstruction. Exclude the hernial orifice, exclude gallstone ileus, exclude any masses, any obstruction. But you excluded all the causes, but you didn't find the transition point, okay? So most likely this is adhesive. Sometimes it's difficult and it's challenging to detect the transition point, but write this one. It's most likely adhesive, okay? But it's much better to identify where is the transition point to help the surgeon how to deal with these cases. Try also to identify small bowel feces sign. We will see this one, ascites and small bowel feces sign. Those signs, if you find long segment of small bowel feces sign and ascites, so we are dealing with high grade intestinal obstruction. It is not low grade. Take care of this point. Search for small bowel, long segment of small bowel feces sign and ascites. Search also for single or double big sign. That means single or double transition point. Fat notch sign. Fat notch sign, that means angulation of the mesenteric vessels. If you find angulation of the mesenteric vessels, so you are dealing with closed loop obstruction. Whirlpool or swell sign, twisting of the mesentery, also a sign of closed loop obstruction. Try to identify the causes that we mentioned before. Try to identify the complications. We have 2 main complications. Remember this one, ischemia and perforation. Perforation and pneumoperitoneum or ischemia, you should search for pneumatosis intestinalis and portal venous gas. Okay, this is my own approach for any case of small bowel obstruction. Again, small bowel obstruction can be classified into these categories. In your opinion, you should mention these classifications. For example, findings are suggestive of high-grade closed-loop bowel obstruction located at nephrectomy bed complicated by early bowel ischemia. Those are some samples how to write your opinion for small bowel obstruction. Okay, I am sorry to take a long time in this discussion, but let me go to the next case. Candidate number 11, a case of left-sided abdominal pain. If you want to scroll.
Sir, if you can scroll for me, please.
Okay, no problem.
I've been provided with the axial slices of CT abdomen in portal venous space.
Yes.
And the patient presented with a left-sided abdominal pain.
Yes.
I'm looking for any obvious pathology. I'm unable to find any pathology at the moment.
Yeah. Okay. I think I did like you said now, because really I couldn't appreciate a gross abnormality, but really when we discussed with the clinician at once at the table, he said that the pain is more localized to the left side, maybe left groin pain, maybe left iliac pain, something like this.
I'm trying to follow the large gut from the this is the sigmoid colon, which appears normal. Can you go up from here, please?
Okay.
Okay, the sigmoid colon appears normal.
Okay.
And there is some thickening of the large gut with the luminal narrowing.
No.
I guess there.
No.
No.
Yeah.
All
We
right.
have left loin pain or left iliac fossa pain.
Okay. Can you show me the bladder? There appears to be a calcification, little bit calcification at the PUJ.
Okay.
At the VUJ, is there yes, vesico-ureteric junction? There is some thickening and small calcification.
You are right. Perfect.
So this can
Perfect.
be a calculus stuck at vesico-ureteric junction, causing the left lumbar
Something
pain.
there is something abnormal in the uretrovesical junction.
Yes.
Is that correct? Okay.
Yes, there is some
Yeah.
thickening and some calcification.
Okay.
So I
should you
would
do?
like to trace the ureter back up to the kidney.
Okay.
There is no significant hydronephrosis in the
Yes.
kidney.
Yes, you are right.
Uh,
What should you do?
Get a delayed image to see the excretion of the contrast into the ureter. Yes, here I can see that there is a focal mass lesion,
Yeah.
focal
Yes.
thickening at the
Yes.
vesico-ureteric junction.
Yes, you are right.
But it is not causing any significant
Back pressure.
or hydronephrosis.
You are right. Really, this case was very strange, and I know that this one is tricky between our GIT cases. But my message is to check all the organs, not only the GIT, but really this patient was complaining of left abdominal pain, maybe left groin pain, if we need to specify the pain. And really, once we have something abnormal in this area, I requested to do delayed image. And this is like, as you said, we have endophytic polypoid mass lesion centered at the left vesico-ureteric junction. We don't have any gross, extrinsic gross. We don't have any extrinsic gross, soft tissue gross, but also we don't have any significant back pressure change, as you said. Okay, what's your next step?
Why was he having pain without any back pressure?
Yeah, it can be happened. Sometimes there is a stone, intramural stone inside the ureter, and at the same time, we don't have any back pressure, but we have left groin pain. It can be happened. Really, it's not common, but it can be happened in our daily routine practice. Okay, what's your next step?
Then I would advise the urology referral of this patient to do the cystoscopy and biopsy of this lesion to rule out any transitional cell carcinoma.
Yes, you are right. You are right. Endoscopy and biopsy. And also, if we need to make proper staging MRI of the pelvis using contrast enhanced study and diffusion with image to properly classify or stage this mass lesion. Okay, that's good. Thank you so much, candidate number 12.
You, sir.
It's a tricky case, but you did very well. Thank you so much.
Thank you.
Can we go to candidate number 13? Candidate number 13, are you here? Okay, candidate number 14, are you here? Candidate number 14, are you here? Okay. Candidate number 15. Candidate number 15, are you here? Candidate number 15.
Assalamu alaikum, sir. Yes, I'm here.
Okay. Are you candidate number 14 or 15?
I am 15.
Okay, go ahead. Abdominal pain, if you want to scroll.
So are you scrolling?
Okay, you can send to me. If you want to scroll by yourself, send to me a request from your remote control.
Okay. Sorry, I cannot find today the icon to send request. 1 second. Yes, here. Yes, I have requested.
Okay, go ahead.
Okay. Sorry. I can scroll now.
Okay. Just a minute.
Okay.
You can scroll from here.
Okay, fine.
Candidate number 15. We have a case of abdominal pain.
Yes, I'm starting now. So this is a CT scan abdomen in the portal venous phase in a patient who presented with abdominal pain. I am scrolling through the images. There is a small ascites noted in the perihepatic region. There is evidence of multiple dilated fluid-filled small bowel loops in the center of abdomen with adjacent fat stranding noted. There is I'm looking at the ileocecal junction.
Yeah.
There is a dilated loop of small bowel in the lower abdomen, which is showing some internal internal air density, suggestive of small bowel feces sign.
Yes, you're right.
Suggestive of small bowel obstruction.
Okay.
I will trace the bowel to look for the transition point.
So you have an evidence of small bowel obstruction.
Yes.
And you have feces sign, small bowel feces sign.
Yes.
Okay.
The large bowel is mainly collapsed.
Yeah, you are right.
And can I see the coronal?
Coronal, okay. Just a minute.
Okay.
Can you give me the hand?
Yes, sure.
I think the coronal venous is more important. Just a minute. Yes. Okay, go ahead.
Yes, in the coronal images, I can again appreciate the dilated small bowel loops. The transition point appears to be there is dilatation till the ileocecal junction.
Okay. What about? I'm sorry to disturb you. What about these small bowel loops? We have here.
Yes,
what is this one?
There appears to be some swelling of mesentery here.
Okay, but here we have collapsed small bowel loops at the iliac loops.
Okay. So
do you agree? This is the ileocecal junction.
Yes,
this is the ascending colon.
This is the ascending colon,
cecum,
yes.
And this is the ileocecal junction, and this is the
Right.
terminal ileum collapsed.
Right. So I can see an area of narrowing in the distal small bowel loops.
Okay.
That appears to be the transitional point, and there is then proximal dilatation.
Okay.
So I will look for any other areas of narrowing to rule out possibility of inflammatory bowel disease.
Okay. We don't have any evidence of inflammatory bowel disease.
Okay.
Okay, but you don't have. I think here we have like transition point at this area between dilated small bowel loops and collapsed bowel loops.
Yes.
Is that correct?
Yes,
Here,
right.
this is a transition point between the dilated and collapsed bowel loops. This is the exact transition point, and the feces sign here, the retained feces or the retained enteric contents can form like feces inside the small bowel. This is the feces sign, small bowel feces sign. And by the way, it is helpful to identify the site of the transition. Once you have the sign, so you are very close to the transitional point. Okay. Right. Also, when I said that if we have a long segment of small bowel feces sign, and also we have minimal ascites, we have a minimal ascites, minimal fluid collection. Once we have two signs, so we have here high grade small intestinal obstruction with a transitional point, single transitional point at the right lumbar region, at the distal iliac loops. And most likely, the cause, what do you think? One transition point. What do you think is the most likely?
One transition point, this could be due to stricture.
Okay, stricture, okay. Maybe also
adhesions.
The most common adhesions, yeah. Yes. Adhesions and stricture, okay. But adhesion or adhesive band is the most common. And really, this case was operated and proved to be adhesive intestinal obstruction. Okay, right. We don't have any bowel perforation. We don't have any bowel ischemia.
Right. No
all
free
of these are important.
areas. Yeah. No pneumobilia. Okay.
Fine, yeah.
Thank
If
you.
you go to this one, look for the axial plane. I think we have minimal, very minimal acidic fluid at the right paracolic gutter. So we have here high grade, look for this is minimal acidic fluid. So we have here high grade small intestinal obstruction, simple small intestinal obstruction. It's not closed loop, okay? Right. Thank you so much, Kent, number 15.
Thank you.
In your mind, really, I'm sorry because my pen was not working. But if we have an obstruction or obstructing cause as a transverse colon, for example, and is it considered as closed loop obstruction or not? Yeah, it is considered as closed loop obstruction because we have an obstruction at the large bowel and we have ileocecal valve proximally. So the dilated segment, it will be entrapped between the colonic obstructing site and the ileocecal valve. So it is considered as a form of closed loop obstruction. Take care of this point, and it can be associated with high possibility of colonic perforation, most probably as a cecum. Okay, I think that's enough for today, and I hope you enjoyed our session today. Inshallah, next session will be abdominal pain, and we will finish these GIT cases. And inshallah, we will shift to the chest case, inshallah. Okay, thank you so much. Do you have any questions?